Thank you, Horatio, and thank you for that interesting title. But it's a wonderful subject, and I'm really glad to be here. I want to thank the leaders of the organization for the opportunity. Yeah, okay. I have nothing to disclose. So this handsome gentleman is Pablo Luis Mirizzi. He is an Argentinian surgeon who actually was born and trained in Cordoba, Argentina. He's probably most famous for having written about the first intraoperative cholangiogram in 1931. But we're going to talk about his namesake, Mirizzi's syndrome. That seminal paper was published in 1940. Of interest to type 2 Mirizzi, I learned this in preparing the talk, was actually first described by Dr. Pusteau. This is a cartoon, I think, that shows the situation pretty well, at least for Mirizzi type 1, and we'll go into the subtypes in the next slide, and an associated cholangiogram. It is a rare condition, thought to only occur in about 0.1% of all patients with gallstones. It is also a bit of a vexing situation because a few series have written that the incidence of cancer in these specimens can be as high as 28%, but most agree probably closer to 5%. But so an underlying transformation of a gallbladder cancer needs to be of concern anytime you encounter this scenario. The scenario can be, or the syndrome can be identified preoperatively. I think the point of this talk was to talk more about the incidental finding in the operating room, so I'm going to try to focus on that predominantly, but here's preoperative imaging showing a dark stone that's actually compressing externally on the common bile duct on the left, and then similarly on the right, you can see a fairly dramatic change in the caliber of the distal common duct. This situation can present in a number of ways, and one we're going to probably focus on most is this patient that presents with cholecystitis, and as such probably was seen in the emergency department, got an ultrasound, and is taken to the operating room without further ado. Most typically they would have a bilirubin less than 4 that may or may not be associated just with cholecystic hepatitis. Of course, as that bilirubin starts to go up, the notion of choledocholithiasis is possible. I think in this situation, one better not be taking care of somebody with cholangitis and septic shock, rather their biliary tree should be drained prior. Once again, don't forget about the notion of cancer, and of course, don't mistake hepatitis or PSC or IgG4 related disease. But let's talk about this intraoperative consult, which is usually when I get involved in Mirizzi's syndrome. The syndrome has been broken down by kind of 2 expert authors, and I have a references page at the end of the talk for those of you who want to look at those references, into basically type 1 and type 2, which differ in whether or not there's a fistula or the ability to close the cystic duct. My experience has been the fistula often is not at the level of the cystic duct, but actually is above the cystic duct confluence between the gallbladder and the common hepatic duct. The type 3, type 4, and type 5 are just how bad has the duct really been damaged in the situation, so they're kind of the extremes of a type 2. This was the easiest algorithm I could find, and we're going to keep that to the right that says yes out of it. This is where the patient presents with jaundice or perhaps with cholangitis, and that drives clinical decisions to get additional imaging, and ultimately those patients will get an MRI or an MRCP and ultimately may go down to get ERCP, appropriate diagnosis made, and then referral or an appropriate operative approach is in place. On the converse, what I want to focus on today is intraoperatively when you discover this situation, and it starts just like the previous speaker talked about with almost impossible ability to obtain a critical view of safety. If you look at the type 1 versus type 2, this author actually said it was okay to try a laparoscopic cholecystectomy provided you could get that critical view. Strongly recommends getting a cholangiogram. The type 2, you'll not be able to get that critical view because, as I mentioned, the fistula is often above the cystic duct confluence, and so as such, you'll not be able to get a critical view. And that's going to lead to conversion in the right hands, or if you find yourself there and now getting a little more worried, you can do the bailout procedure, as was mentioned. You'll see both pathways suggest obtaining frozen sections, just to get some insight into whether or not you were really dealing with a cancer. But these parts are often very woody, thickened, and the stone itself, when it's lodged in the cystic duct, makes it very, very difficult to grasp the gallbladder laparoscopically. And so you're going to see I'm going to give you a few pearls here, and then I'll sit down and get ready to answer questions. So first of all, as I mentioned, if the patient presents jaundiced, you want preoperative imaging above and beyond an ultrasound. And the big focus is it cancer? And I'm going to show you a picture here when you get that preoperative imaging that kind of tip things off, but this is a patient that I was referred, and there's two things to point out. One is look at that lymph node, that's a pathologic lymph node, and two, look at the fuzzy borders of the gallbladder, and so sadly this is a gallbladder cancer presenting with obstructive jaundice due to portal adenopathy. Other pearl that I've learned along the way is open up the lateral wall of the gallbladder if you're open. You can actually fetch the stones out. Sometimes you'll actually observe the fistula from the medial wall of the gallbladder as a separate opening to the cystic duct. But it certainly will help protect you from injuring the common hepatic duct or main bile duct because you'll see the medial wall. And it's one of those ways towards incomplete cholecystectomy. It gives you the opportunity to fulgurate the mucosa and then do some sort of closure. If you do have a fistula, get a cholangiogram through it. I really think less is more in this circumstance. When people call me from the operating room, if it's a type 1, we will, for the most part, do a partial cholecystectomy, making sure we open up the duct and refetch the stone, because don't forget that stone can be lodged way down, and you may think you've done a partial cholecystectomy, but you have not alleviated the biliary obstruction, and that's not really something a postoperative ERCP can readily fix. If you do have a hole in the bile duct that isn't readily closed and you haven't had a preoperative ERCP, I put a T-tube right in it. You don't need to create a separate ductotomy, but rather use the fistula. And I have taken ducts that were at least 50% disrupted by the fistula and put a tube in them and left a drain next to them, and then slid in a little bit of false form ligament. Just curious, how many of you have all placed a T-tube? And who hasn't? If you put a T-tube in, just the most important thing I'll tell you is that those things like to dislodge. So you need to make sure you give more than enough length inside the intra-abdominal cavity and really focus on that as you're closing the abdomen to make sure you haven't left it short, because most of us will bring it out just below the rib cage, and with a deep inspiration, the patient will actually avulse it out of the bile duct. The other thing I do is pexy it up either to the fundus or where the gallbladder was, or you can use the false form, but I use some vical sutures to try to hold it there even more securely. And then I just want to emphasize, this may be adequate, a T-tube and a drain next to it, and I just pull that T-tube at 6 weeks, but it's okay to go to ERCP afterwards, and I do that as early as 2 weeks, and we can actually pull the T-tube and then cover up the defect with a covered metal stent and leave that in place and allow that area of injury to remodel over a sizable caliber, and that's typically all you're going to need to do. I have not had to do a roux reconstruction. Was asked a couple of friends whether they had ever had to do a roux reconstruction, but I think most felt that better saved for a later date if possible, because the inflammation will be so bad. Better get control of the bile duct and come back on another date if you do face a stricture down the road. Thank you.